I'm Rich Besser. I'm going to be moderating this session. I'm the Chief Health and Medical Editor at ABC News, formerly with the Centers for Disease Control and Prevention. And I'm thrilled to be here at Skoll for the first time to be moderating such an important session. The way this session is going to run, I'm going to engage our panel here in conversation for the first 40 minutes, and then there are a couple folks in the audience that I wanted to direct questions to, and then all of you will be open to dive in. So please think of questions, and I'm going to try and keep it flowing. Yesterday was a big day in Sierra Leone. The children in Sierra Leone went back to school, and that was for the first time in 9 months. Just an incredible thought that children in that country had not been to school for so long. This is the largest Ebola epidemic in world history. It started back in December of 2003 in Guinea, near the border of Sierra Leone and Liberia, and then spread from there. The latest report from the World Health Organization from yesterday, the epidemic's not over, but it is getting closer. There were no cases for another week in Liberia, and if this continues, as of May 8th, Liberia will be declared Ebola-free. In Guinea, there were 28 cases. In Sierra Leone, there were 9 cases. In total, there have been more than 25,000 cases and more than 10,000 deaths in the 3 most affected countries. So this is a very good time to look back, but also to look forward. To look and see what were some of the critical gaps that allowed this epidemic to take off, and to talk about whether there were aspects here that could have been prevented. Was this totally unpredictable, as some have said, or were there things that could have been done differently that could have prevented such a major loss of life and an economic catastrophe for that region of West Africa? And most importantly, what needs to happen so that the impact of the next health threat will not be so large? I worked at the CDC for 13 years, and at the end of my time there, I led the agency during the start of the H1N1 flu pandemic in 2009. And I have to say, when I went to Liberia back in August, nothing I had seen in my career in public health had prepared me for what I saw there on the ground. It was absolutely apocalyptic. And it's the first time that I'd been in the midst of a major health disaster as a journalist and not as a public health responder. And so this is in the U.S. there's a feeling that people don't want to talk about Ebola anymore. There was so much fear in the U.S. That it blunted a lot of how people felt emotionally about what the suffering was going on in West Africa. But we're going to tackle it here today. And I have a terrific panel of folks who are going to be doing that. On my left is Miatta Gbanya, who is one of the top leaders in the Ebola response in Liberia. When you look at emergency operations and how you direct a response, she is one of the people who has been calling the shots for the response in Liberia. Next to her, Paul Farmer, the co-founder and chief strategist and Skoll awardee, chief strategist of Partners in Health, also professor and chair of Department of Global Health and Social Medicine at Harvard University. Next to Paul, Tony Banbury, who is the former head of the UN mission for Ebola emergency response. He's currently the Assistant Secretary General for Field Support at UN headquarters in New York. And our last panelist is Eric Goosby, who is the UN Special Envoy on Tuberculosis. From 2009 to 2013, he was the Ambassador at Large and U.S. Global AIDS Coordinator, overseeing all of the U.S. government international HIV/AIDS efforts. So I want to ask each of you a question just to get us started. And the initial focus I want to take is on the gaps that occurred in many different areas. But the first question for you, Miatta, when you first recognized that there was an Ebola outbreak going on in Liberia, What did you see as some of the biggest infrastructure gaps?
Well, thanks, Rich. So before I respond to the question, just to put things into perspective, I kindly ask that we observe a moment of silence for all of the many lives that were lost in Liberia, Guinea, and Sierra Leone, and with the hope that never again is going to happen. And at this time around, we will all be much more prepared, that we've learned so much, and lives will not be lost again. Thank you. March, when the first case was recognized in Lofa, Foya, at the border with Guinea. First infrastructural gap. The first thing is to say that the specimen that was collected had to be taken to Gegedu in Guinea. And what that meant was that we did not have the capacity to test the samples that we were collecting. And what it also meant was that the time it would take to get, because of the road network, was a bit difficult. And it also meant that patients that needed to be treated on time, treatment will be also delayed. So that's one first thing, laboratory. Our ability to have laboratories set up to test for Ebola patients, which is critical to making the right diagnosis. Also, with identifying that someone was positive for Ebola, what it also meant is that the patients had to be isolated. Did we have isolation facilities? The big answer is no. We have places that we could keep patients, but they weren't really set up to be able to cater to Ebola patients. And because of that, we did see that a lot of positive patients that made it through our routine healthcare facilities, that was a calamity. We had a lot of healthcare workers that got infected because of one patient going through without proper triage system in place, proper isolation for them. So if I count the numbers, for a small country like Liberia, we had about now 372 healthcare workers infected and 189. That's a good percentage, right? Yeah, that's a loss. It's a loss simply because amongst those who died in the process of caring for patients were doctors, were nurses, were mental health clinicians, were community health workers, were professors at our medical school and nursing school. So that's a big loss. So we didn't have the right isolation facilities and triage in place. Also, for some of the places that we were having patients coming from, the road networks was terrible. I remember places we had to go in flights just to be able to take some PPEs. And time is of essence in such an emergency, and we struggle with that quite a lot. How do we get to the places? Logistics. The ambulances, the Land Cruisers, the motorcycles, all of them were limited. Communications. We needed to get data from the field. And it's only with data coming from the field that we at the Emergency Response Center could make some informed decisions. There were places people had to put the telephone up on the hill or on the tree to get some signal just to be able to pass information. So it meant that in some of those dark places, even the cell phone to pass the information could not be charged. Electricity. I could go on naming. There were a lot of critical gaps. And I'm speaking about Liberia, but I'm very sure it's the same thing that happened in Sierra Leone and Guinea.
Thank you. We'll come back to a lot of those themes that you've raised. Paul, NGOs played a major role in the response here. We're on the ground treating patients long before the global governmental public health community came on board. Partners in Health played a role here and continues to play a role in providing treatment. But this is not an area that traditionally Partners in Health has been involved in. What gaps did you see that led you to decide that Partners in Health should provide Ebola treatment?
Yeah. Well, Miatta started the long list, right, of gaps. And you yourself said that in years of doing public health work, you hadn't really seen anything like whether it was rural Liberia or urban Liberia. And as Miatta has said, that's true across the region, right? And, you know, just because there's so many things to remember, you know, sometimes this mnemonic, you know, that I apologize for overusing, but we have to do it to sort out our response. The infrastructure gaps are human infrastructure as well, human resources, so staff, stuff, space, and systems. And, you know, first of all, you know, on the personnel, the staff side, even before Ebola, there were maybe about 50 Liberian physicians working, like, you know, Miatta, in the public sector, which is in charge of responses. Larry Brilliant says, you know, outbreaks are inevitable, you know, pandemics are optional. So just to knowing that we can make this list go on and on, I just want to say that the reason Partners in Health was there is because we knew after the wars, civil wars in Liberia and Sierra Leone, by the way, Guinea, 10% of the population of Sierra Leone was in Guinea one time. You know, so this is a regional outbreak, right? There are national polities involved. They all need their own laboratory infrastructure, just like you have at CDC, right? But after the war, there were billions and billions of dollars invested, but not through Liberian institutions, not through Sierra Leonean institutions. And so this long struggle to build local capacity, you know, I think that's part of the missing infrastructure, is that we were not adding up as the international community to more than the sum of our parts after the wars ended there. That's over a dozen years ago. I was last week in Harper, in the south. Yeah. Can I say?
Yeah.
You know, let's just say you know Harper. It looks like the war ended last year, you know, and so it's not rebuilding these systems; it's building them, you know, for the first time.
And was there something different about the quality of this outbreak that led you to jump in?
Well, I'll say one thing and then allow other people. Personally, for me, 30-something years ago, I wanted to go to West Africa. It just took me 30 years because I applied for a Fulbright. I said, I'll surely get the Fulbright. I didn't even get an interview and ended up in Haiti as Plan B. But I eventually did get there. It just took 30 years. And we knew that if you look at the world, you know, the map, you know, some of these groovy maps, that this is the part of the world with the weakest health systems and low levels of public financing of healthcare. So when we, first time I ever set foot in Sierra Leone was June for a meeting that on surgery, including cesarean sections, I'm looking at your brother, and I only knew 3 people in Sierra Leone. And of the 3, 2 of them were dead of Ebola, you know, within one July 29th and the other October 17th. So yes, there are personal reasons, right? But mainly there are structural reasons.
Thank you. Tony, in September, the UN decided to establish the UN system Mission for Emergency Ebola Response, UN-MIR. What gaps did the UN see to decide that the WHO wasn't cutting it and another organization needed to be established?
Thanks, Rich. I'll answer that question, but give me leeway to say what Paul didn't say in response to your question and why PIH went there. Because we were heavily involved in trying to get agencies in, just like the Liberian government. And a lot of agencies were afraid, a lot of NGOs were afraid. And Paul and PIH, to their great credit, looked at this situation and said, oh my God, the world needs more response. And they were brave, as some others were, and many weren't, and were were willing to run into the burning building instead of running out, and they were bumping against people who were running out as they were running in. So PIH and Paul personally, I think, deserve huge credit for taking that risk and throwing caution to the wind. To answer your question, though, and a little bit in the same vein as Paul, I mean, continue the long list of gaps, but what was so striking in September, and I was appointed the UN Ebola crisis manager on September 8th, so when the crisis was well on its way, and I'm not a public health expert, I don't know anything about public health or Ebola, but what was really glaring at the time was you were hearing people like Tom Frieden, the director of CDC, like Jim Kim, the president of the World Bank and a public health expert, like Tony Lake, who's the head of UNICEF but had been the national security advisor under President Clinton, all of them saying, as you did a moment ago, they had never seen a crisis like this before, never seen something of this dimension. I mean, they were scared, and they were scaring the rest of us like, oh my God, we are in a really unprecedented situation, facing an unprecedented crisis that it could take on dimensions that were just unimaginable. And Tom Frieden came up to the UN in New York and briefed all the member states in mid-September, and having just, I think, briefed President Obama and that team on where the numbers could go. 1.4 million cases by January. And so it was clear to the Secretary General and the rest of us working on it that we were in an unprecedented crisis. There was no playbook. We had to throw caution to the wind and dive into this crisis. The second thing was this inexorable math, and the experts like Tom and Jim and others kept beating us with the math that with an exponential growth in the caseload, doubling every 3 to 4 weeks, if we don't get it under control fast, we're not going to get under control. We'll just, building the isolation beds and the labs and everything, it can only go forward at an arithmetic rate, more or less, and if we see a continued exponential growth in the caseload, it's just going to be impossible to control. So time was very, very much our enemy, and we, the world, had to move really, really fast. And then just the last thing, and this is really directly related to the question, the key gap from the UN perspective was there was not a crisis management approach to the crisis. There was a lot of good work being done, first and foremost by the governments, more and more by local communities, certainly by some NGOs, by some UN agencies, but there was a lot of isolated islands of good activity that was creating benefit where it happened in that location. But there was no plan to end the crisis. There was no response plan in place that said, these are the things we need to do to get to zero. This is who's going to do what. These are the performance measurements. These are the resource requirements. And this is how we're going to track it and see how we're going. And so the basic role of UNMIR essentially was, at least for the UN system, to play that role of overall crisis manager, to manage the crisis in a way that would not just do some good work here and there, but get down to zero cases.
Eric, you've had many roles in terms of U.S. response to major public health crises around the world. When you look at something like the Ebola epidemic, is this a once in a lifetime kind of event? I mean, Paul had mentioned the outbreaks happen, pandemics can be prevented. It was said much better than that, but Larry's the attribution will continue to shift. Is this a once in a lifetime event, or is this something that as a global community we have to think about happening again?
Well, thanks, Rich. It will happen again, if not from Ebola, from another disease process. It speaks to a level of first response and second response that needs to be linked, and that linkage and need for that linkage needs to be anticipated by people in country, mainly government authority, in playing the orchestrator role for the public and link to the NGO community for that initial response needs to be mapped out. The ability to monitor on a surveillance level outbreaks and have a rapid response to identify, confirm, and contain it is something that really the country needs to own and be prepared to do. To have a cadre of individuals who are standing ready is unrealistic and can't be afforded, but to have a Rolodex of individuals in country, as well as the critical gaps in that continuum of needed services that needs to be deployed with an outbreak, you can be very efficient in having people who can be deployed to contain it. And that's what a lot of the thinking has moved into now post the peak of this outbreak. That infrastructure takes time to set up. It takes time to get to work correctly in terms of information systems, procurement distribution systems. But the conversations that can grease the pathway to that can happen before the event, and that will facilitate earlier engagement. But there will always be a crescendo of awareness that will happen with an outbreak. You can't anticipate all of it, but you can anticipate a good amount of it. And that marriage didn't really occur in this setting.
I want to dive back in a little more and have you engage with each other as well. Around the concept of infrastructure. We're focused on infrastructure, but it's a word that has different meaning to different people. You talked about staff, stuff, spaces, and systems. There's infrastructure at the international level, at the national, at the regional, down to the local level. Let's explore a little bit further. What do we mean by infrastructure at those various levels? What do you see as some of those key pieces of infrastructure that maybe haven't had as much attention as they should have?
Well, I think when a lot of times when we look at infrastructure, the first thing that comes to everyone's mind is a building. And I should say a building is nothing when it doesn't have the ingredients. So if we took a health facility, you think about I can build a massive hospital. But that hospital needs other things to function. It needs the staff, it needs the equipment, it needs the supply, it needs to be maintained. So it goes beyond just a building. It goes beyond just a structure standing up. The systems are the ones that's linked, and it all has to be maxed up together.
Paul?
Well said. And I just would add that, again, the idea that there can't be surveillance capacity and the capacity for decent care in West Africa is just absurd. The idea that there can't be. We all said that there wasn't. You said that there wasn't. There isn't. But there has to be. That's local capacity. Now, the setback is, the Rolodex, which I feel like I have to translate, Eric, to those under 50. So it's a thing. Anyway, never mind. The Rolodex has to also have Liberian and Sierra Leonean and Ghanaian names on it.
Yeah.
Right? So it takes a long time to train people, but it doesn't take so long that we can't anticipate it now, right? That's, I guess, what I'm saying. Too bad that didn't really happen after the last crisis, meaning the end of the war, because there should be universities of global health equity, for example, to train, professionals there. I just would say one thing, because there's just been so many illustrations. The only exception to the Sierra Leonean colleague was another surgeon who, the year before our surgery meeting, which again happened in June. So you can imagine, as the host, the first meeting was at Harvard, the third one in Dubai. So we got to have, it's a meeting on surgery in resource poor settings. We better have it in Africa, not South Africa, not Rwanda, where we'd been 11 years, but somewhere where there's enormous need. A professor of surgery, probably the only one left, at the main referral hospital in Freetown, wrote a paper last year comparing unfavorably the surgical conditions in district hospitals, that's the public health sector, last year, this is before Ebola, with the American Civil War, the conditions of the Union forces, surgical conditions, way before antibiotics. And you can sort out the comparison yourself. His name is T.B. Kamara, no relation to TB like tuberculosis. So, if we don't acknowledge these disparities require rebuilding public, and when I say public health capacity, I mean both the surveillance but also the delivery locally, then we're just going to stumble again. And as Eric said, the last time we had a zoonosis come out of equatorial Africa, not the last time, but one of them, it went into a worldwide pandemic. And it was the leading infectious killer of young adults within 20 or 30 years after its discovery, HIV. And, to act surprised every time is a huge mistake.
Tony, I want to ask you a little bit about the global public health response infrastructure. The secretary of WHO has said that this epidemic caught everyone by surprise. It couldn't have been predicted. But as you dive into it a little deeper, you see that, well, actually, maybe it didn't catch everyone by surprise. It had been recognized for months before a global health emergency had been called. The UN set up UNMIR as an organization, in part in recognition that WHO is not getting the job done in terms of leading this response. And when you look at some of the internal communications at WHO, there were a lot of political considerations in terms of how things should respond and what should be declared. Is the global public health response infrastructure broken? And as some are saying, does there need to be something different from what WHO has?
I think it's pretty clear it's broken. It's not serving the needs of the people of the member states of the UN, and the Ebola crisis is a very clear expression of that. The big question is, okay, what should be done? And there is a lot of attention now on how should the world be prepared to deal with a crisis like Ebola, like Liberia was facing in August, Sierra Leone in September. And yes, that question needs to be asked and answered, but it's, in my view, the wrong question. It's much more what should be done to deal with the situation that existed in March and April, which gets to the kinds of stuff Paul and Miatta have been talking about with investments in health infrastructure and surveillance and all that. But for the UN and the international structural or organizational system, I think that we need to distinguish between public health crises and multidimensional complex crises that are driven by a health or disease issue. And Ebola very much became the second. It was handled as the first by the public health experts, but then it took on all these other dimensions, social, humanitarian, logistics, et cetera, and that wasn't recognized and responded to until much too late. So there needs to be a certain role for WHO, and that could be debated what it is, but we shouldn't ask WHO to do things that it's never going to be well equipped to do. And I think in this case there was an expectation on WHO in terms of its emergency response capability, not its public voice, which should have been much louder, but in terms of its emergency response capability, that wasn't warranted based on what member states had kind of resourced it to do.
And I mean, that's something that has occurred with HIV back in the swine flu pandemic as well. WHO was saying they didn't have the resources, the money that they needed to be a response organization. Does the world, and this could be for anyone, does the world need to have a global response organization that it currently doesn't have?
I think it does. The question is, should it be WHO? Should we build a big emergency response capability in WHO? And Eric is absolutely right. You can't have this big standing capacity that's just soaking up resources and waiting for the next emergency. So it has to be done in an intelligent way. But as Rich, you and I talked about a little before the session, a fundamental problem in WHO is the political influences on what should be purely health and scientific decisions. Mm-hmm. And the way WHO is now structured, with the regional directors being elected by ministers of health makes them very susceptible to political influence, and that really played out in this crisis.
Eric, last summer, or in September, Tony was talking about public health leaders coming to the UN, going to Washington, many places, talking about how bad this crisis could get. The exponential growth in cases. If you looked at the epidemic curve, it was absolutely frightening. The U.S. pledged $1 billion and thousands of troops. And in the New York Times on Sunday, the U.S. response was criticized in a big way. Hundreds of millions of dollars in aid were spent. 3,000 troops were in Liberia. 9 of the 17 promised treatment centers were built, and 28 patients were treated. Did the U.S. get their response wrong? And what will this mean in terms of future cries for assistance?
I think that the threshold for the United States to engage needs to be lower. And I say the United States because it is the largest country with the largest GNP. It's a rich country. And there is something, and I would attribute this to Paul Farmer, drilling this home for me many years ago. There's an ethical responsibility to respond because you can. Just the fact that you are able to respond puts an ethical agenda on your plate. And the discussion that occurred in the US government really did shift not to just the fact that the resources were available and needed to be allocated quickly, even though it was long after the fact. You know, as Tony's saying, you know, this should have been what was the response should have been in March, you know, when that response was generated. But I would say that the United States went through a very reflective discussion about why should they be the only country that puts up that response. So not to deter that decision, that was a good decision, it was late. Had it come in earlier, it would have been a different trajectory, but we still offset the 1.4 million. Okay, all of the work that happened, we did not achieve those threats, the numbers that Tom brought to the UN in the 1.4. But I would say that the nimbleness of that deployment of resource, going to treatment sites versus you know, individuals who would go out for contact tracing, and not being able to move the resources from what, as they got on the ground and deployed, were not needed. And was there an individual who was in a position to call the fact that they weren't needed? In other words, we don't need this many treatment units, we can shift those resources to something else. There was not that kind of nimbleness in that allocation decision, and I think that is a real problem that needs to be noted and understood and then responded to. Could be avoided. Those resources could have been shifted on the ground decision to the part of the response that would better position the containment effort, and it wasn't. So there's those types of issues, but that's a little bit in the weeds, if I could say that. But I think it absolutely needs to be understood and studied and then fed back into future responses. I do think that the lack of infrastructure that was present as the conversation started is the deficit that is continuing to reverberate through the post-epidemic and in the wake of the primary response as you move now into a maintenance phase. You are really in a position now where these types of kind of reflex reactions can be laid in much better. So it's hard for me to criticize if you kind of follow my thinking there. Yeah.
A question for you, Miatta. In response to a comment actually that Paul is quoted as making, Paul, you said at one point that Ebola should be used as a wedge to give countries what they really need, which is their own institutions, and that in taking care of Ebola patients, you build systems that solve other problems. When you look at the response and the resources that have come to Liberia as a result of Ebola, do you see these having any impact beyond this current epidemic? Are there systems and things being built that will have a positive benefit? I mean, there's so much written about what hasn't gotten done because of Ebola, immunization campaigns and nutrition programs and basic primary care. But is there anything that has come to Liberia as a result of this that could be a positive moving forward?
I think there are a lot of positive things that have come true. And the first thing I would mention, I think, is more in terms of human capacity to some degree. I think we had an opportunity for people that were able to brave the storm to come to Liberia, to work within most of our different thematic areas, be it the U.S. Army, the AU, the NGOs. There was a lot of work done with our teams that sets the basis for us to start to move forward. In terms of infrastructure, some systems, of course, with the surveillance systems, we did have a lot of people working with us on that, and that's going to continue, and even focusing on a more regional approach to that. But I would say we are at the tipping point where we went down much faster than we expected. And I think the conversations that have been happening in country, like Eric said, is how some of those resources that are still present for Ebola, how can we use some of those resources to fund our investment, to look at post-Ebola? How flexible are the people with the money going to be to make sure that we can determine what we want to give them, what we want to fund right now, will make much more difference and actually compensate for the world not coming very early. Yeah. Yeah, and I think that's what we should be thinking about now. We spent the last couple of 4 months trying to look at what have we learned from the Ebola epidemic. What are those critical gaps that we have had? We've criticized ourselves and saying as a government, what should we have done differently? And I think it's a good starting point, because by looking inward and really trying to say, could we have invested in our public health institutes? Could we have invested more in our physical infrastructure? Could we have relooked at and redo things in our facilities? So I think the point will be, yes, we have benefited in a lot of ways, and the capacity we have now that we didn't have 12 months ago. I haven't manned an Ebola response before, but I can probably say that I can go somewhere else and I can shake it up a little bit. So I think that's good. Yeah, that's good. But how we can turn what we have, the finances that we have that is in country now, for the benefit of Liberia, Sierra Leone, and Guinea will be a good start.
Thank you. I want to ask a question to a couple people in the audience. The first one is for Raj Punjabi, who's here in the front. He runs a program called Last Mile Health, which is focused on getting healthcare to the most remote villages in Liberia. And Raj, Sue Terrell, who led the Oxfam outbreak response, she was quoted as saying that the success of the response wasn't really about building big treatment hospitals. It was about engaging in the community and engaging with people at the local level to change practices. And she said if a greater emphasis in community engagement had happened much earlier, it's more likely that many fewer lives would have been lost. And what does this mean in terms of the type of infrastructure that is needed? And the question for you is, if you could go back in time to that day that patient zero developed fever in rural Guinea, what systems would you put in place to prevent the global pandemic that was to come?
That's a good question. Besides trying to slap around the fruit bat, I think, I'm only kidding. I think that, well, first of all, I think the premise of the question just needs to be considered. It's really not either or, facilities, communities. It has to be all of the above. And I think that's been made clear. If you have a specimen that's in a remote rainforest region that comes forward, and you have to take the specimen from 8 hours in the rainforest to another country to get it sampled and tested. There's risk of transmission there. You have to have the things that I think Paul, Miatta, and everyone on the panel have already spoken about. That said, where those components, staff, whether it's community health workers, nurses, systems, the space, the stuff, where that's applied is really critical. We've designed the entire effort in global health around HIV, TB, disease, even platforms. We're not talking about who and where, and that became really critical in this crisis. There's 1 billion people on this planet who have no physical access to care because they live in remote villages, like this little boy, Emil, who became known as patient zero in this crisis, who died after fever, vomiting, and diarrhea in the rainforest. He lives in villages that are 50 to 350 people that take hours to go on. The capital expenses are higher to serve them. The operating expenses are higher to serve them. Markets, there are not enough consumers in one place to make it a market opportunity. All of those factors played the precedent for this little boy to come down with a fever. There was no existence of a real primary care system for this little boy. He comes down with a fever. There's not a real health worker there. The hospital's hours away. He gets sick. His sisters get sick. His mom gets sick, his grandmother gets sick. That spreads from one village to several villages, one country to several countries. It wasn't until 3 months before this was recognized. Well, what happened between December 2013 and March 2014? Why did we recognize it in March? Why couldn't we recognize it then? And I think if Ebola and threats like it are threats to people anywhere, everywhere, then part of the answer has to be getting a health system to work for anyone, anywhere. And that largely certainly starts with professionalized community health workers, but it means it's not hard rocket science. It's a community health worker for every village, paid, supervised, coached, supported, does surveillance, does primary care, a nurse to back him or her up, a clinic that's supported and does good infection prevention control, a hospital that can care for it. All of that's needed, but again, I think we need to change our bias against remote areas of this planet. If places are too small and they don't have enough people in one place, it's not scalable to go serve them. We have to change that thinking altogether. That's what really bit us this time, is a lack of, think about the spending in that place, the spending in regions in Lofa County in those areas, the spending in the government, $60 per capita nationally. We had risen that. It was $3 per capita when I first started working there with Miatta 10 years ago, coming back from the war. 3 to 60 is a great leap. Look at the remote districts. Do the math on how much was spent in healthcare, period, whatever it was for. In some of the districts we were working in, it was 76 cents per person per year. What can you get for 76 cents per person per year? So the distribution has to be evaluated. And so my short answer to this is to say, cost of inaction higher than the cost of action, but it turns out we can still do something about this right now. She has a health investment plan that the government's put together to get 5,000 professionalized community health workers, to get clinics going, to get hospitals going. We in this room should continue to rally behind that plan and get it done. If we're really serious that this is historic, we should have a historic response and a recovery.
Thank you. A question for Larry Brilliant. Where are you in the audience? Very good. Larry is the president of the Skoll Global Threats Fund and a leader in epidemic and pandemic response. Larry, I want to ask you a question having to do with data and the importance of data in preparing for and responding to a health crisis. I remember back with H1N1 the predictions of what that flu pandemic would look like, and early on trying to make decisions based on some of the modeling. It was very hard given how inexact those models were. With this epidemic, we were hearing back in the fall that as many as 1.4 million cases of Ebola could occur if there wasn't massive international response. And so far there have been 25,000 cases of Ebola, the worst epidemic ever, a total tragedy, but not on the apocalyptic scale that was predicted. The predictions from the fall drove a lot of governments in terms of what they committed to this response, and many are now wondering whether or not they should believe the next cry for help. Can you talk a little bit about what modeling is good for and how it should be currently used.
Thanks, Rich. First, I'd like to introduce Annie Maxwell, who is my successor as the president of the Skoll Global Threats Fund. And I thought you took the job back. We're all no.
I didn't get the update. Sorry.
Who we're all very proud of and thrilled that she's here. 2 or 3 years ago in this very room, Paul was here. Some of the rest of you were here. We showed a movie called Contagion that one of Jeff's company, Participant Media, made. And the reason we made that movie was, Rich, exactly as you're saying, after the swine flu epidemic of 2008, there was a feeling that the world had overreacted, that we had cried wolf because public health community said it could get really bad. And in fact, it got terrible. There were at least 1 billion people infected with that virus. There might have been 2 billion people infected with that virus. That was the most transmissible virus in human history. Never has there been a virus that affected so many people so quickly, but it didn't kill very many. Maybe only 300,000. Only 300,000. We're talking now about 10,000 from Ebola. Maybe that influenza outbreak killed only 300,000, and the world was disappointed in some strange, bizarre way. In fact, every year, the annual influenza pandemic, although we don't want to call it a pandemic, do we? The annual influenza pandemic kills maybe 350,000 every year. So the numbers become a little strange. We made that movie to model what a real pandemic would look like, more like the swine flu pandemic of 1917-18, which killed 25 or 50 million or maybe 100 million, as against a population that was about 1/3 of what it is now. Today's terms would kill hundreds of millions of people. And that's what this excellent panel has just said. They've just said, we shouldn't be surprised. It's going to happen again. It's inevitable. And Tony, thank you for your candid comments on the structural inadequacies of the response that we have right now. So I would say that when you look at numbers and you try to predict what is terrible and bad, it gets a little bit squirrely. And when you model, and specifically your question about modeling, those models were made against the worst of everything you could think about, and particularly the worst of human nature. Those models were based on poor response, because up until that moment, there had been poor response. But the world rallied in a way that it has rarely done before. I mean, not just the United Nations General Assembly creating out of whole cloth a new specialized agency in, what was it, under 14 days. Can you imagine creating a UNICEF or a UNESCO in a short period of time like UNMIR was created? Can you imagine the groups like Paul's group? I mean, the dozens of evangelical Christian communities who rushed in, heedless of their own safety? In Silicon Valley, hundreds of millions of dollars, I think it was $1 billion, was raised from private enterprises, from the Medicis of Silicon Valley now, the new Wealthians in Silicon Valley. But all around the world, people rushed to help. That's one of the reasons why we didn't hit the worst expectations, because those models were based on the worst expectation of human nature, and we disproved them. But what we didn't disprove is the inevitability of viruses jumping from animals to humans, of which there have been 3 dozen in the last 30 years, any one of which could become a pandemic on the scale of 1917-18. And I'll just leave you with this one thought. Ebola could never really become the kind of pandemic that we're talking about in our worst nightmares, because it's a blood-borne disease. It's not a respiratory-borne disease. H1N1 did not become the worst disease we could imagine, because it had a remarkably fortunate turn of the roulette wheel, the genomic roulette wheel, and it didn't have that lethal killing gene. Now imagine a disease that spreads like H1N1 and kills like Ebola, because that's what we're worried about, and that's what we have to build a 21st century global governance system to deal with, because unfortunately, if we don't build something like that, we will become subject to the tyranny of it.
Larry, I know that you're just back from Berlin. You were there with Bill Gates and others as part of an independent expert group on pandemic response. The meeting was under Chatham House rules, but is there anything you can share just between us here? Exactly. Yeah. Just don't look at the camera. And
I think maybe the new president of the Skoll Global Threats Fund would be. This year at TED in Vancouver, Bill Gates rented an entire auditorium and outfitted it like a Ebola treatment facility in Liberia. Even had several hundred spacesuits ready for all the folks at TED to put them on, go in, and try to give an intravenous injection to a hypothetical patient with those clumsy gloves on and not cut yourself. Bill has become quite consumed with the potential of a pandemic to bring humanity to its knees. He wrote multiple op-eds simultaneously in the popular media and in the scientific media. And in fact, he did, at the request of Angela Merkel, put together a group of people to think about what the global world needs to look like in the 21st century. Now, the interesting thing is that was one committee out of at least 15 that I know of, and Paul would add more to that, I think, and Eric would add more, and Tony would add more. In fact, Laurie Garrett of the Council on Foreign Relations published an article last week listing 15 groups that have met in order to ask the question of how do we need to govern ourselves when we're dealing with events of low probability but catastrophic results. What do we do in the inter-pandemic interval that Tony was talking about? How do we have a standby force that becomes ready but isn't always being paid for? So these are the questions we need to wrestle with. And this you guys have just done a fantastic job. You're hitting every single issue. This conversation shouldn't stop until we have the world governance that we need to have to deal with the problems that we're going to face. And I thank you so much for having such an articulate and intelligent conversation here at Skoll World Forum.
It's now time for all of you to participate. There's a microphone that will pass around. If you raise your hand and would like to ask a question, please identify who you are and what your organization is. And if everyone doesn't know what your organization does, you can give a little one-liner on that too. So we'll start over here, and then back there, and then here, and then we'll work our way around.
Thank you.
Oh, and just before we start, if you can keep it short, there's a lot of hands going up. I'll use my prerogative and cut you off if it doesn't become a question. Thank you.
Andrea Coleman from Riders for Health. We started talking to the Liberian government Ministry of Health just before the Ebola outbreak about mobility and running vehicles and the maintenance and management of logistics for healthcare just before the Ebola outbreak. And that conversation had to stop when the Ebola outbreak came. But we're now back in Liberia, but I'd really like to congratulate them on being the only ministry we've ever talked to who have thought about how the people donated a lot of vehicles, and they really have thought about how to make sure those vehicles take them through the crisis and out the other side, and make sure that they keep on running and they're not wasted assets, and they really make sure that rural communities are reached predictably and reliably, and support health workers. So I just wanted to congratulate them on that.
Thank you. Back over here, I think. Was it you? No?
Yeah, okay. I can speak without the microphone, actually.
No, we need it for the video. Thank you.
Okay, my name is Astrid Zweinert. I'm from the Thomson Reuters Foundation, where I work as a journalist on our website, Trust.org. And my question is really about, I sometimes wonder whether globally, the global health response is too much focused on a disease by disease basis. You know, we had Ebola, shocking, tragic, but there's so many other diseases that also kill a lot of people. You know, TB, I think, kills a person every 30 seconds or something like that. Then there is the economic impact of global disease. There was a big study out last year that said about 25% of global growth over the last decade actually was due to better healthcare. So there's a big economic impetus to provide better healthcare globally. But it strikes me that we're sort of lurching from one disease to another that gets a lot of attention, but there's no real holistic approach anywhere to look at how universal healthcare, for example, can be happening finally. So my question really is, what's your view on that? Why is there such a sometimes such a narrow focus?
Paul, I'll let you kick off on that. Are we too focused on a disease approach rather than a systems approach?
Well, I think, back to Raj's point about it's not either or, we have to keep doing that. Like, we clearly need, as Larry outlined, and Tony, and Eric, and Miatta was too polite to outline it this way. We have to have the ability to respond to trans-regional epidemics of rapidly moving pathogens, right? There are 21 families of viruses, more or less, that cause disease in humans, and it's just not it's not unfeasible. We have to do it for the reasons that are laid out. To Astrid's point, we're saying the end of Ebola. And one of our biggest problems, I think, is Ebola triumphalism, because, we have major outbreaks of pertussis, measles, maternal mortality, which was already the highest in the world in Sierra Leone, is, maybe 1,300 per 100,000 live births, is by some estimates now 2,000. So again, just like Dr. Kamara speaking about surgical conditions and the American Union forces, they're set back to feudal times. Forget about Civil War times. And the only way to take that on, to Astrid's points, is health system strengthening. And we need a sexier term, I mean, for God's sake, Larry and Jeff Skoll and others, at least they can, make a cool film called Contagion. Imagine the film Health System Strengthening, part.
I can tell you our news at ABC would not do a story.
I know. Trust me, Rich. Trust me, Rich. We've tried. Okay. No, seriously.
Yeah.
We have not been able to get people interested in universal health care and global health equity, and in these problems, and we need to. I mean, for the reasons that Larry laid out, but also because to die in childbirth, is outrageous in the 21st century, and that's just what's happening.
We'll go here, and then we'll move to another part of the room.
First of all, this is like the scariest thing I've heard since, I don't know, The Exorcist maybe, but this is real. Truly, this panel was terrifying. And it's terrifying partly because I know some of the people on it, and if they're saying that, it's really scary. Rich, the question's really for you. We live in a country where people don't believe that there's climate change, and it's reinforced by political leaders. When this story broke, there was a little bit of good coverage, but then, and you were doing your damnedest, but they stuck you 20 minutes in and led with a poor health worker who was trying to get away from everyone in Maine and was being made into Typhoid Mary. If the American public isn't willing to put their arms around some of these issues, then we're not going to get them funded. The political leadership is not going to be there unless it comes from the ground up. You're now the journalist. You used to be a government official. What happens there? Because you can't count on the news media to take that lead anymore.
Yeah, I mean, that's a great question. I think there are a couple things in there. One is that the level of science literacy has to improve. We have to be able to teach people about risk and disease and these issues in a much better way than they're getting right now. Because while there was a true epidemic of Ebola going on in West Africa, there was an epidemic of Ebola fear going on in the US that made it very difficult to talk about Ebola in any kind of a rational way. But I think the way you break through it, though, is not by talking about health system strengthening. It's by doing what I see a lot of what's going on here at Skoll, and it's focusing on how do you tell a story. And you can tell a story that is all about health system strengthening without using any of those terms. It's
I want to see you do it.
no, well, it's talking about, it's showing what 3 years ago, I got money from Gates Foundation for global health coverage. And most of the stories I told were of Skoll fellows who were around the globe. And it was in Bangladesh, showing a carpenter who couldn't work, and showing his life transformed by putting on a pair of reading glasses that were there as part of a...
Did you read AIDS and Accusation?
What's that?
Did you read my book, AIDS and Accusation?
I haven't.
I'm kidding.
Yeah.
Nobody did.
No, but it's about, even there it's a high bar, I gotta tell you, but by telling a good story you can connect to people in a way that you can't with other things. And it may not be, and when you think about news media, the audience for what is considered the legacy or traditional news media is shrinking and shrinking, and the outlets for getting messages out are becoming democratized. There's so many ways to get stories out that have nothing to do with what we control at 6:30 in the evening and 7 in the morning. So it is an exciting time in that area. And I promised I wasn't going to be on the panel. I would just moderate in the back here.
Hi, I'm Corey Shepard-Stern, and I'm actually making a film about global health system strengthening called... Thank you.
That's not the title, though.
No, it's actually called Bend the Arc. And I've been chasing Paul around for 5 years with a camera, so among other people. And I've lived in Liberia, and thank you very much for the moment of silence. My children are Liberian. I've spent a lot of time in Rwanda. And I'm trying to decide which question I want to ask. I think I'll go with South-South collaboration. So I'm a big fan of Health Minister of Rwanda, Agnes Binagwaho, introduced to her through Paul, and she's also been here at the forum. And I'd love to know, having spent time in Rwanda and spent time in Liberia, and seeing the incredible change in Rwanda, and honestly, there has been an incredible change since I've been working in Liberia as well, and I don't want to discount that at all. I mean, it's, we're coming up, So, but I would like to know about what's the role of, South-South collaboration and learning lessons from, from Haiti, from Rwanda to, to Liberia and Sierra Leone.
Who'd like to dive in on that?
Eric? I could just say something briefly about it. In PEPFAR, the President's Emergency Plan for AIDS Relief, there was an initiative called the Medical Education Partnership Initiative that attempted to target 18 medical schools in sub-Saharan Africa and have a curriculum change, create a faculty layer, so there's an attending physician layer in the teaching hospitals, to teach basic epi and clinical skills around clinical investigation. So the tools that are needed are there in the medical school, and to have that medical school partner with ministries of health to serve as many of the medical schools in Europe and the United States do. When there was an outbreak in San Francisco in 1981, the UC San Francisco partnered on day one with the Department of Health and thought through a plan. And that plan stuck and merged skill sets that are not always reproduced in both institutions. That's going on at a small level, 18 medical schools, but it has rippled to create a cadre of health professionals who are now in a different dialogue about what that curriculum should contain, what studies they can partner with and work on together, which creates a coalition that is brought into a problem in a country through a medical school that they know someone in another medical school has already worked on, way beyond our expectation. But it's been alluded to on the panel. It's about institutional presence. And the older I get, the more I really realize if I could do everything over again, I would look for institutions to infuse and capacity expand because they're there. And they are there on day 1, on day 365. They're there when we leave. And I think are the ultrastructure of that sustainable response that is country-defined and country-driven. And if I could, I was just going to comment on the universal health care idea. It is the unifying theme in the room for the Ebola epidemic outbreak to allow us to pivot as a planet into the necessary building blocks that will result in developing a continuum of services for everybody on the planet. That's, I believe, what has been put up. And I think that we can take our health system strengthening needs and put it into the context of a narrative, of a story that says every person on this planet should have the following services in this age group, with this gender, and map it out. And the UN, as you know, has passed a universal health care. They've 193 member states have voted it in. It's the first time in the history of the human race it's happened. And I believe it's the groups like this, people in this room, who are going to make that a reality. So I think that's how to pivot.
Are we out of time, or can we go long? Who's the timekeeper? Can we keep going? A couple more. Okay. One here, and then here on the left side, because I feel badly that I have not looked to the left. Yeah.
Olivier Delarue, I'm the lead of UNHCR Innovation. I'm the co-lead of the UN Innovation Network, which is a new group created inside of the UN. What is really striking me is the lack of capacity to capture the innovation that happen in the response theaters, and the capacity also to evaluate this innovation in order to be part of the prevention and response capacity in the future. So it's really about having this at the forefront, and it's also responsibility to the UN to do that. But it's really striking me that this innovation concept has not been even mentioned today, while a lot of great stuff happened on the ground.
Thank you. Miatta, do you want to comment on that at all?
So it's obvious there's a lot of things that did happen. And internally, one of the things we were really trying to do is to try and document some of those things that have happened so that they can be used for the future. So definitely we probably haven't mentioned, but there's a lot of things that went into really trying to make this work, how we got to where we are now.
And last question down here, and then after that, we'll hang around if people want to come down and ask more.
And our question is really about what could be done to prepare for the next one in a way that strengthens the systems. There was many gaps, but there was lots of supply that did not meet the right gaps, that was ready to be there. I would like to issue an invitation to the panel, but really to everybody in the room, to do a rehearsal meeting, a tabletop exercise a year from now, to see if the right bottom-up innovations, to see if the right supplies of things that could have helped up front, like contact tracing, airline staff training for readiness, CDC readiness to respond with their own staff and helping the US respond. All the systems that didn't quite work. Let's see where we are a year from now, and let's see if strengthening the basic everyday systems are leading us there. Lots of diagnostics are coming out for things like Ebola. Let's make sure all diagnostics data can get to the right destination. Lots of healthcare workers could be trained rapidly. Let's make sure they can all use their mobiles to detect something earlier as possible. And it's not a big deal to do a rehearsal. Let's rehearse 1% of the time and perform 99% of the time if we can.
Thank you.
And how do we do that? I don't know, but it's for the panel.
One last thing for each panelist before we go, this to keep short, but we were asked as part of this for a call to action. And so I just want to ask each of you, what one thing would you like to see take place in the next year at either the local level, the regional level, at any level, that would help us be better prepared for the next big health crisis that could come our way. So just one thing that you would like to see as part of, not everything, but as part of that call to action. Yeah.
So I guess as we think about it, it's about time that we stop and think a little bit that diseases and outbreaks and epidemics requires not just a medical intervention. So to all of you in the room, the private sector, the philanthropists, you all have expertise that could help governments, that could help country system grow up. We are open and ready to tap onto some of those resources that can help us set up better systems to be able to man something like this if it ever happens before, which we don't wish to. But just to take a moment, as we have gone through this, and we will get to zero, one of the things that I want to remind all of us is that it's not over until it's over. And those of us who are the responders, the survivors, have not only just survived Ebola, but they do have other medical complications. There are a lot of orphans, there are affected families, and for some of you that are interested in mental health and psychosocial support, Liberia, Guinea, and Sierra Leone will need your support. Thank you.
Thank you. Paul?
But just picking up on what Miatta said, making it very pragmatic around survivors. So one of the common complications, or we don't even know if common is the right word, but something we've seen again and again, is ophthalmologic complications, visual loss. But there are only, just to give you a number, in all of Sierra Leone, there are 2 ophthalmologists, all right? And I think there's 1 in Liberia. So that's just an example. It's not that you want a medical response, but so here's my wish, because it can be translated into all of these efforts: health system strengthening, the aspiration towards universal health care, the ability to respond to a number of threats. And that is, some of the resources that have been pledged to emergency responses have to pivot, to use Eric's expression, into building local capacity, health system strengthening. And really, I'm not kidding when I look at you and say, we've got to be effective at communicating that story, because it clearly boring or something. It should not be so hard to do. We're working with Miatta, we're not going anywhere, but we don't have electricity in these places. We don't have supplies. And that's for, there are other problems going on, not just for the survivors, but for everyone who's been shut out of modernity in that part of the world for a long time.
Tony?
Thanks, Rich. Of the hundreds of things that I'd like to see, really the most important one is, I think, what Larry was talking about, a continued conversation on what's the right governance and structures in place to deal with epidemics of this nature in the future. And that's both at the community level with good surveillance and early detection, but it's very much also at the strategic global level if there's a crisis of this nature. Because honestly, UNMIR, the US military, terrible tools for response, very inefficient. But given the options available in September to the UN Secretary General, to President Obama, I think they were both the right choices, as inefficient as they were. We need a global governance response capability and system that is tailored to this and not inefficient and inartful the way that the UN and the US and others were.
And Eric, you get the last word.
Okay. I think that my wish would be that we understand the importance that the Ministry of Health plays in creating the primary response and linking it to the global infusion of resource. Without that link being strong and capacitated, it doesn't reach the ground. And I would very much, and I know everybody on this panel knows this deeply, but the narrative now has to shift to we now need to understand the determinants of performance for ministries of health, and we need to converge on them to expand their capacity to play that orchestrating role.
Well, I want to thank all of our panelists, all of you in the audience as well, for your participation. It was a wonderful conversation, and thank you for your time.